Hello, everyone. Happy holidays. I wanted to thank you all for your support. This is why I would like to share a little bit about gingivectomy in order to give back to you. And this is such a powerful tool in your hands to enhance the smile of your patients. And I would like to answer a few questions that came up in the comment section of my last two posts. So let me ask you. This is one of your patients, and she's bothered about her gummy smile. What would you suggest? What would you recommend to do? So you can see the excessive gingival display. Ideal gingival display is 1 to maximum 2 millimeters, and here we have like 5 to 9 millimeters. So would gingivectomy be ideal for her? What is our decision roadmap? So when we think of the ideal length to width ratio of the tooth, it's probably 10 to 9.5. So it's almost as wide as it is long. We know that the ideal length to width ratio is about 10 to 8 millimeters. So there is room for improvement. And here I've drawn the ideal tooth shape in terms of length to width ratio. And you can see that even if we did a gingivectomy, she would still have a gummy smile. So gingivectomy alone is not the ideal solution for her. So there are a few treatments that could be suggested to her. One would be surgical impaction of the maxilla to set the maxilla further up to disguise the gummy smile and reduce the vertical axis of the maxilla. Probably if she's visiting a periodontist or a prosthodontist, they would probably suggest to do surgical crown lengthening and then do crowns on the teeth. However, what I suggested to her, what I think is something that is really cool, is if we do intrusion of the teeth and then gingivectomy on top. So, because we already stated that gingivectomy alone wouldn't solve the gummy smile. And here is how I check if gingivectomy would be a good idea or not. So I look at the picture where you see the clinical crown. So the clinical crown is what you see with the eyes and the mouth. And then I check the CBCT and I check the size of the anatomical crown. So how big is the crown? Indeed, also the part that we do not see because it's hidden underneath the gum. And here you can clearly see that the anatomical crown is far bigger than the clinical crown. So there is an amount of gingival overgrowth. So gingiva covering part of the enamel is normal. However, sometimes it covers a lot of the clinical crown. And in the CBCT, you can also check the bone level. So you can see that there's a 2 millimeter distance between the bone level and the cemento-enamel junction, which we know as the biologic width. And this biologic width will reestablish. So if the bone is grows, or if the bone touches the cemento-enamel junction and we do a gingivectomy, those 2 millimeters will reestablish because there needs to be a little bit of distance between the bone and the margin of the gingiva. And what I like to use, so many of you asked me if I do bone sounding, which I do not. Bone sounding means that you anesthetize the patient, the gum, and then you put a probe all the way through the sulcus until you hit the bone, and then you check where the bone is. because my patients come for orthodontic treatment to me, and I do a CBCT because they're adults and there's an indication to do a CBCT. I like to check it in the CBCT. It's far less invasive if I have to take that record anyway. So this is a very interesting case to check for the discrepancy between the clinical crown and the anatomical crown. So the clinical crown is very short. The tooth is as wide as it is long. But in the Approver software, you can enable the gingival display, and then you see how long the anatomical crowns are indeed. So she has a perfect length to width ratio. Actually, she has very long teeth, but it's not visible because the gum is covering those beautiful teeth. So that, in combination with a thick band of keratinized gingiva, would be an ideal indication to do a gingivectomy. And here's a little cartoon of the difference between the movable mucosa and the attached gingiva. So this would be an example of gingival overgrowth. We have a lot of attached gingiva covering the clinical crown. And whenever we have that would be ideal to do a gingivectomy to improve the length to width ratio of the tooth, enhance the smile, enhance the proportions, and make more of the beautiful teeth visible. So here you can differentiate the movable mucosa from the attached gingiva. The attached gingiva is fixed on the bone, and it has these little dots. And the movable mucosa, you can move it around. It has not this strong attachment to the bone. It's rather mobile. And attached gingiva serves like a protective collar to the tooth. So we want to keep that. We don't want to remove it all the way, because if we remove it all the way, then when the lips keep pulling on the mucosa, it will not stay on the tooth, and it is likely that we create recessions, which of course we do not want. So we already stated that in that case, gingivectomy alone would not solve the problem. And the treatment plan that I proposed, that you can propose to your patient, is to do an impaction of the maxilla with TADs, with orthodontic mini screws and aligners, and do a gingivectomy on top to improve the length to width ratio. But we need to fix the gummy smile with intrusion of the upper teeth. So this is a really cool advancement that we have due to the possibilities of mini screws, that we do not have to go for very invasive surgery, but can choose a minimally invasive approach. So here you see the initial picture. We intruded with aligners and TADs, and on the right side you can see after the intrusion. So it was possible to achieve a big amount of intrusion, and now there's still a little bit of gummy smile left, which will be fixed with gingivectomy. And I want to give all the credits to Dr. Trevor Nichols, who developed this protocol of gummy smile treatment with TADs and aligners. If you want to learn how to do it, I recommend the Fellowship in Aligner Orthodontics. He's teaching you in that course how to do it in your patients. So I think another very important thing to mention is when not to do gingivectomy. So for example, if you see teeth like that, and let's say this patient also presents with a gummy smile, there's no reason to do a gingivectomy because the length to width ratio of the teeth is already ideal. We do not want to make the teeth any longer. That would look really weird. So here's no indication for a gingivectomy. The length to width ratio is already ideal. So a very, very common case where you would want to do a gingivectomy is, for example, here we have a patient with class 1 on the one side, and she had a class 2 on the other side. We did symmetric extraction of premolars in the upper jaw, and you can also see the gingival overgrowth. Like the teeth look very, very small, and there's not a lot of wear. So excessive wear on the teeth also affects the length to width ratio, of course. So here in her case, premolar extraction was done. We closed the gaps, and by closing the gaps, we have a lot of gingival tissue that is accumulating between the teeth, and usually makes the teeth look even smaller because of all the excessive tissue. So that was after taking braces off, and you can also see that the gingival margins could be really improved. So she already had some kind of surgery somewhere else, and I thought that the gingival margin looked very, very triangular, and other than exposing more of the anatomical crown, I also wanted to recontour the gingival margin. So this was after the gingivectomy, and you can see how beautiful teeth she has, which were covered underneath the gum. You can see that I've recontoured the gingival margins, that I also touched the papillars, because we need to have a nice emergence profile when we do the gingivectomy. So it's not enough just to cut it like that. We also need to do a bevel. Okay, we want to have a very natural looking gums. And today I would be even a little bit more aggressive. I would take away even more. I would set the margins even more, a little bit more cervical, because we need to expect 1 millimeter of rebound. And to explain the bevel a little bit, so first you define where you want your new margin to be. You recontour the gingival margin, and I do it by having the instrument run perpendicular to the tooth surface, all while staying in attached gingiva. We want to keep that protective color to the tooth. And then I do the bevel to debulk the tissue, and I hold the instrument at a 45-degree angle to the root or to the tooth. This can be quite intimidating if you do it for the first time, but no worries, we got you covered. So in the Fellowship of Aligner Orthodontics, you can even learn how to do gingivectomy. So here you see a sneak peek of an exercise that you have to do where you mark the gingival zenith. So the gingival zenith makes it really easy for you to do free-handed gingivectomy, because it's basically connecting the dots. So here you have the gingival zenith marked for those central, lateral, and canines, and you just run it from one papilla to the gingival zenith to the other papilla. Very easy. So here, let me show you how you do that. So you're shipped a mannequin head, a phantom head, with those bone models that are very realistic, and you do those exercises in a simulation. So that gives you all the confidence you need to then do it in your patients. Sorry. Okay, so that was after the gingivectomy. Here you have the comparison before and after, and note the thick papilla where the premolar was extracted and the gaps were closed. And after that, we did the gingivectomy. So I did the gingivectomy back to the 6, because of course I want to expose the clinical crown of all the teeth, basically, where it's necessary, because otherwise she will just have big 6 front teeth, and then the other ones are really small. And we want to have harmony in the smile. So I did the gingivectomy until the 6. Here's the right after. So the upper picture is right after the gingivectomy. There's usually no bleeding. So in her, I debulked a lot of tissue. This is why it's a little bit reddish. And in the picture below, that was, I think, after 7 or 14 days. So it will heal. I instruct the patient to brush normal, so they can be rather aggressive. It's not like we did periodontal surgery where we did a huge flap, a full thickness flap, and this is all very fragile. No. There's still attached gingiva, so patients need to brush. If they don't brush, they will get a gingivitis, which of course we do not want. It takes a little bit longer to completely heal. So if you do a mild gingivectomy, you will have initial healing after 7 to 14 days, but the gums, the margin will still be a little bit reddish. So after 3 months, there has been enough turnover of the tissue and healing so that it looks very natural and normal. So here the before and after. And you can see how it dramatically changes the attractiveness of a smile if you expose how beautiful the teeth really are. Here are your take-home messages. So remember, the ideal length to width ratio is about 10 to 8. 10 in length, 8 in width. We want the teeth to be longer than they're wide. If the tooth is as wide as it is tall, if it's really looking squarish, it could either be wear when we want, that would not be an ideal case for gingivectomy, but if the reason for the disproportion is gingival overgrowth and we have a thick band of attached gingiva, that's a perfect case to do gingivectomy. So how to check for overgrowth? Basically, that means we want to see the discrepancy between the clinical crown and the anatomical crown. I prefer to use the Spark Approva software because I can upload the CBCT, I have the teeth and the gum from the scans, from the intraoral scans. I match it, and then I can enable, make the gingiva visible or invisible, and then I check, okay, what is the clinical crown, what is the anatomical crown. With the gingivectomy, we want to expose the anatomical crown, but staying in the attached gingiva. Expect 1 millimeter of rebound, so don't be shy, it will regrow again. Instruct the patient to brush normal, and the initial healing takes for about 14 days. If you want to learn all these cool things, how to treat a gummy smile with pads and aligners, how to do finishing touches such as gingivectomy, or how to solve every problem with aligners, class 2, class 3, severe crowding, whatever, I highly recommend the Fellowship in Aligner Orthodontics for orthodontists. So this is an advanced course, and it will transform your practice and how you offer orthodontic treatment to your patients. Thank you so much for all your support. It's really a lot of fun to do those things. Please ask everything you want to know in the comment section, and I'm wishing you very relaxing and refreshing holidays.